And thanks everyone for joining. It's my distinct pleasure today to introduce the speaker. Most of you who manage individuals with OI or know anything remotely with OI would know Frank Rauch. Dr. Rauch is a professor of pediatrics and a clinical scientist at the Shriners Hospital for Children and McGill University at Montreal. Dr. Rauch obtained his MD from the Technical University at Munich and trained as a pediatrician at the Children's Hospital at Cologne, both in Germany. He has been at the Shriners Hospital for nearly 2 decades, and since 2001, his research program as well as the clinical activities concentrate on improving the bone health in children with rare genetic bone disorders. He has identified many new genetic causes for brittle bone disorders. He is a world expert on bisphosphonates in OI, and Dr. Rauch is published extensively on OI and other bone disorders as well. We're really glad to have him as the speaker. Dr. Rauch, you can take it away.
Okay, thank you, Sandesh, for the introduction. So I will try to get my screen sharing working here. Okay, Oop. So, and make that bigger. So, okay, so I'm going to talk about the medical treatment in children with OI. Here is my disclosure page. So when you talk about the medical treatment in OI, I think it's important to realize that there is several problems in the bone of children with OI. There is low bone mass, but then there's also low bone quality. And finally, there is bone deformities, at least in the more severe cases of OI. And any medical treatment that is currently available will increase bone mass, or that's at least what we hope to achieve. But there is no direct effect on the other problems. So any medical treatment is only partially addressing the problems of OI bone. One important thing to consider here also is that medical treatment will not prevent fractures in deformed bone. So if you have a tibia like shown on this X-ray, you can give any medical treatment that you like, you will not prevent fractures. And this is surprisingly often not considered. Even in publications, sometimes I see X-rays of deformed bones and people comment that the person continued fracturing. So medical treatment will not be able to improve the bone to the extent where it can withstand the forces that arise in the context of bone deformities. So for these bone deformities, of course, we need surgical treatment. The bones need to be straightened out, and then the patient needs to have physiotherapy to make the muscles smooth and increase bone strength with these methods. And then as an adjunct treatment, medical treatment is helpful. So with this out of the way, we can focus on the things that we like to talk about, which is the medical treatment. The current standard treatment really is bisphosphonates. And here I'm just showing a few that we have been using. The most widely used kind of treatment nowadays is intravenous bisphosphonates, but there is also oral forms of bisphosphonates. So what the bisphosphonates have in common is their mechanism of action. So the bisphosphonate molecule is attaching to mineralized surfaces, and bone has plenty of those. And so when the osteoclast is attaching to the bone and resorbing the mineralized bone containing the bisphosphonate, then it will have high intracellular concentrations of the bisphosphonate and get inactivated. And because the osteoclasts are the only type of cells that do this kind of activity, resorb mineralized bone, the treatment is very specific for inactivating osteoclasts. The immediate effect or very fast effect in children is that bone density increases. So here is the first 7 patients in Montreal that received the bisphosphonate at the time when the arrow indicates this. and all of them had an increase in bone density closer to the normal range within a few years of start of treatment. What you can also see in children receiving bisphosphonates is that each treatment cycle, when you give infusions, results in a line in the metaphysis. So you can see how often the treatment was given, and you can estimate the interval between 2 infusions from that. What we have seen when we took biopsies in the area of the ilium, where there were also sometimes these lines, is that these horizontal, these lines that you see in X-rays correspond to horizontal trabeculae. So that are shaped like the growth plate was shaped at the time when the infusion was given. What you can see from the biopsy here also is that there is mineralized cartilage in the middle, which is the light green material. But there's also bone on the outside of each trabecula, and you can also see that the amount of light green material decreases with increasing distance from the growth plate. So we can say that these treatment lines represent trabecula that are horizontally located and that probably undergo remodeling like any other bone. The other effect on bone mass that is more pronounced in children than in adults is an effect on cortical bone. And we saw that from iliac bone biopsies initially. So this is the iliac biopsy of a 3-year-old boy at the start of treatment. The cortex is this green area on both sides. And you can see that the cortical thickness more than doubles in 2 years of treatment. And in children, this is a very consistent finding that cortical thickness increases. You see that much less in adults, of course, because the growth is not there to make this happen. So there is no studies really that are randomized, controlled, and have looked at the effect on long bone fractures in a controlled fashion. There's a number of observational studies, and one example of this is shown here, where they show a few patients that had fractures each time there is an arrow, and you can see that there's fewer fractures after the start of bisphosphonate than before. So similar studies have been also on a larger scale, and usually they report that fracture rates decreases by 40 to 60%. So I want to make this talk quite practical and just approach the questions that are often asked in the context of bisphosphonate treatment in children with OI. So I'm just showing the way we do it here in Montreal, and then explain why these individual choices have been made. So well, when a patient with OI is diagnosed, the question that we ask is, does this patient have moderate or severe bone fragility? And if not, so if it's very mild bone fragility, then we don't treat and just do a once per year follow-up visit. And I will define that later, what is moderate and severe. So then if the patient falls in that category, then we decide to recommend Zoledronate treatment, and our starting dose is shown here, and we give it every 6 months. And then we adapt the dose and the interval of this Zoledronate treatment according to the lumbar spine bone density. So we have cutoffs at -2 set score, at 0 set score. And so that continues as long as patients are growing. So if patients are no longer growing, then we stop the Zoledronate. So I think that's the entire treatment algorithm. So now for the individual parts of this and why we do this. So who do we treat? So in mild OI, which basically means type 1 OI, the most common reason why we start the treatment is vertebral compression fractures. Also, of course, if you have a lot of long bone fractures, this would also be a reason. Or if you have a femur fracture for no reason, really, for a very minor trauma, we would also recommend Zoledronate. But in type 1, the most common cause for starting the treatment is vertebral compression fractures. So that means for follow-up that we do a lateral spine X-ray once per year and check for vertebral fractures. And here you have a case where there are several of these. So that's already quite severe in terms of vertebral fractures. And so certainly we would start the treatment in such a case. So for the patients who are not type 1, well, most of them get treated because they have reasons to be classified for types other than type 1. So they have deformities, vertebral fractures, many long bone fractures, and so they basically all get treated with bisphosphonates. So why do we do intravenous treatment? Why do we give Zoledronate, and why every 6 months? So we did a study on oral alendronate, and that was a randomized controlled trial that was started, I think, 20 years ago, and had randomized or placebo control group. You can see that the lumbar spine bone density increased in the alendronate treated patients, but not in the placebo treated patients, so that was highly significant. We did not see a difference in the incidence of first fractures that was significant. I mean, it was almost significant, but did not quite reach there. Overall, the oral alendronate increased bone density, but it did not seem to be very effective on fractures. Also, in that study, we did not see a detectable effect on vertebral fractures, and we did not see an effect on bone pain. And so that was just less than what we were used to seeing with intravenous Pamidronate at the time. And so that's why in clinical practice, we opted to go with intravenous treatment. So why Zoledronate? Well, we had a lot of experience with Pamidronate, which was our first bisphosphonate in Montreal. And here the initial publication that I have already shown, we saw that Pamidronate infusions were associated with an increase in muscle force. We also published that patients receiving Pamidronate for 3 years and also follow up with physiotherapy and surgery had better mobility than untreated patients. So we had a lot of outcomes with Pamidronate, but the advantage of treating with Zoledronate is simply that this is easier to administer. And here we have the comparison between Zoledronate and Pamidronate. So Zoledronate we give every 6 months. Pamidronate has a shorter half-life, so it has to be given more often. The duration of each infusion is shorter. And also because Pamidronate has a higher dose, you need to separate it into more than one infusion to get the same effect. So in our standard Pamidronate protocol, we had to give it over 3 days. Whereas Zoledronate is just a single infusion in 50 minutes. So overall, kids spent 2 days coming to us with Zoledronate, whereas it was 9 days with the full Pamidronate protocol. And the effect on fractures was similar between Zoledronate and Pamidronate in a study where this was compared. And the effect on bone density was even a little higher with Zoledronate than with Pamidronate. So, the reason why we went for Zoledronate every 6 months is that the effect on bone pain seemed to be better when Zoledronate was given every 6 months rather than every 12 months. And so from my practical clinical experience, I see that some children even find that 6 months interval is too much for them. And they complain of recurring pain before they come for the next infusion. And so then my attempt to improve on the situation is to give the Zoledronate every 4 months, but at the same annual dose. So I just distribute the same annual dose in 3 individual doses. And for some, that has made a big difference in their bone pain. So why do we adapt the treatment according to bone density? Well, the main point of this is to avoid overtreatment. So we don't want to induce osteopetrosis, which has been published by Michael White many years ago now in a case who really received very high doses, who had these Erlenmeyer flask deformities, and on bone biopsies had the signs of osteopetrosis with mineralized cartilage inside of the trabecula. So you can induce osteosclerosis or osteopetrosis if you do the bisphosphonates in an uncontrolled fashion. And so we adjust the dose according to bone density to avoid this from happening. The last item here is, well, why we stop the treatment when the patients stop growing. So why do we do that? Well, initially we had plans to stop the Pamidronate treatment when bone density at the spine was normal, and often that was after about 4 years of treatment. And then we stopped the treatment, but the observation that we made in this context was that, of course, once you stop the treatment, the bone continues to grow. And the newly grown bone has never seen the treatment and therefore is not having these lines and has low bone density. So here it's documented in a 12-year-old girl with type 4 OI. You see the hand X-ray and the distal radius metaphyseal lines. And where the red line is, this indicates a place where we do a PQCT measurements, a peripheral quantitative computed tomography that can measure the bone density and the radius. And so the trabecular bone density here, when this girl was fractured, was treated, was actually above the reference range. She had a set score of +2.6 at the time. And then 18 months after the last treatment, this newly created bone had a bone density of -3.2. So you have a drop of close to 6 standard deviations within these 18 months. You miss that if you just look at the spine density, because that didn't really change. So the bone that is added after the last bisphosphonate treatment is untreated. And we saw a few cases where this seemed to make a difference. So we had several patients who had fractures in the area where they treated and the untreated bone met. So here a 5-year-old boy who had fractures on one forearm and a few months on the other forearm, and both at the same place. And another girl where there was a proximal tibia fracture. So for that reason, to avoid this untreated bone that comes from continued treatment, continued growth, we continue the treatment as long as they are growing. So then the question is, what happens with the treatment? Well, what happens after the treatment is stopped at the end of growth? So we had looked at 31 patients where we treated with first Pamidronate and then Zoledronate until average age of 16 months. So when they had stopped growing, we stopped the treatment, and they had on average received 7 years of treatment. What we saw after the stopping is that bone density at the spine continued to increase even a little bit. So we had 4 years of follow-up in these 31 patients. We also did not see any one of these patients have a vertebral fracture during this follow-up period. At the distal radius, we saw a decrease in the trabecular density. And that corresponds to the fact that on X-rays, you can also see that these these metaphyseal lines, they fade away. And so when you quantify that, you get a decrease in trabecular bone density. We did not see anyone with a fracture in this area during this follow-up, but well, it certainly makes the bone more fragile. So I've shown you the entire treatment protocol that we are using. Now some information on the long-term treatment effects. So the most noticeable effect of long-term treatment, I think, is on vertebral compression fractures. If patients have vertebral fractures at the start of treatment, and if they are very young. So here we looked at a study where patients were below 5 years of age when they started bisphosphonate treatment. And we show the spine before the treatment was started and then after they had finished growing. So the two cases here show quite severe vertebral fractures. One girl at 4 years of age, the other even at just a few months of age. And by the time they had stopped growing, the vertebra had quite nicely reshaped. And that's, of course, something that's specific to children. You don't see this reshaping once growth is terminated. So you need enough time to grow to see this effect. In contrast, this long-term treatment had less effect on the long bone fracture rate. We don't really have an untreated group that we followed and documented the fractures. So we only have the fracture rates in the lower extremity here during treatment. And we see in this patients that had type 3 and type 4 OI that were included in the statistic, they had an average of about 0.7, 0.8 fractures per year. So that means one fracture every 18 months or so. So there's good effect overall on vertebral fractures, not so good effect on long bone fractures. And I think one reason why the long bone fractures still happen at quite a high rate is that the problem of long bones is not really low bone density in OI. What we see when you take PQCT measurements in here, the forearm, is that the bone marrow cavity is very small. The bone actually looks very solid. So when you measure the bone density, it's actually very high, even without any treatment. So of course, a treatment that increases bone density will not have a good effect in a part of the bone that already has high bone density. So there's simply no scope for improving anything much with a bisphosphonate in a situation like this. What you would like to have is a treatment that makes the bone grow wider, so periosteal apposition, and the bisphosphonates don't do that. So we did not see an effect of bisphosphonate treatment on periosteal growth. The bisphosphonate treatment, in our experience with our follow-up, did not have a marked effect on the development of scoliosis either. So we did a statistic here comparing patients with type 3 and type 4 OI that had started the bisphosphonate treatment before 5 years of age, and those that started later, assuming that the ones that started earlier would have a lower prevalence of scoliosis, but we didn't see that. So the early start of bisphosphonates did not really have an effect on the development of scoliosis. And finally, on the function, what we want to achieve in the end with all the treatments combined that we give, so medical treatment, physio, rehab treatment, and surgery, is to make people able to live on their own once they are adults. And so we identified a number of skills that people have to live alone. Then we checked how many of our patients with type 4 OI and type 3 OI have acquired these skills by the time they were skeletally mature. And you can see that the patients with type 4 OI, they almost all could do these things, like transfer from bed. Most difficult thing is transfer into a car. Whereas in patients with type 3 OI, only about a third could do the transfer into a car by themselves. And the limiting factor often was the upper extremity deformity. So if you don't have straight arms, then you cannot push yourself out of the wheelchair so easily, so the transfers become very difficult. And finally, we did a study that was just published recently on predicting the ambulation at skeletal maturity with the information that we had when the patients were 5 to 6 years of age. So we had 88 patients there who started the treatment with bisphosphonates before the age of 6. You see, like type 3 OI had black square of 0, which means they are non-ambulators. Black score of 4 means independent ambulator, and in between, that's some intermediate forms of mobility. And you see that the change in black score after the age of 6 is minimal, or there is no change in most patients. So more than half of the patients kept the same black score at skeletal maturity as at 5-6 years of age. And 30% still improved after the age of 6, and 13% of the patients decreased. So the main predictor of ambulation at skeletal maturity was that they were already walking at 5 to 6 years of age. Then an independent predictor was height Z score. So the taller you were, the more likely you were to walk independently. And weight Z score was a negative predictor, meaning that the heavier they were, the less likely to walk. So some specific clinical situations that I'm often asked about, what to do in case of fracture or surgery. So do we stop the bisphosphonate treatment? We have had a study that was published in 2004 where we found that many bones had unhealed osteotomies after rotting surgery. In particular, the tibia had a unhealed osteotomy that was still visible on the X-ray 1 year after the intervention. And after this initial observation, we changed the way the surgery was done. So the surgeon no longer took a saw, but an osteotome to make this osteotomy. And we did not give the bisphosphonate treatment in the 4 months following the intervention. And then we did a follow-up study that was published in 2015 and found that the rate of unhealed osteotomies 1 year after the intervention had decreased to 42% from 72%. So that was a significant improvement, but still there is a lot of unhealed osteotomies. So overall, our approach is not to give bisphosphonates in the 48 hours before the intervention or in the 4 months after the intervention. We do not adjust the bisphosphonate schedule if a fracture occurs, because we did not see in our studies any effect on fracture healing, at least no negative effect. Another question that is often discussed is there atypical femur fractures related to bisphosphonate treatment? So we looked at all our femur fractures that we had seen in our patients. Most of them were in the context of bone deformities, which really cannot be compared to the situation of atypical femur fractures. So the femur fractures that happened without deformities were 11 during bisphosphonate treatment, 25 without bisphosphonate treatment, and a similar proportion fulfilled the criteria for atypical femur fractures in both groups. So what we found is that the atypical characteristics were related to disease severity, but not to the bisphosphonate treatment. So type 3 OI had more atypical characteristics defined for postmenopausal osteoporosis really than type 4 OI. So that's the bisphosphonate treatment part. A few words on newer treatments. The one that has the most experience is Denosumab. Denosumab also inactivates the osteoclast, but with an antibody. And the difference is that the antibody, once it's out of circulation, has no long-lasting effect. So the Denosumab treatment effect is short-acting, whereas bisphosphonates are long-acting. The initial studies on Denosumab showed an increase in bone density, as expected, but they also showed that between 3 and 6 weeks after the last injection, you already had a re-increase of bone resorption parameter in the urine here. So the effect of the treatment did not seem to last very long. And well, we had published some case reports on patients where this caused some problems. So here a patient with type 6 OI where we switched from Pamidronate to Denosumab treatment. Despite the Denosumab treatment every 3 months, his bone resorption marker CTX increased at the time before each of these injections. And then at some point he missed an injection of Denosumab, and during these 6 months he lost 2 standard deviations in bone density. At the same time, calcium excretion was quite high. So it seems that the bone resorption rebounds very quickly after denosumab injections, and that can cause hypercalciuria, hypercalcemia, and bone loss. So to conclude this whole talk, so bisphosphonate treatment increases bone density, is best in treating vertebral fractures, is less effective in preventing long bone fractures, helps with mobility if it's given as part of a multidisciplinary approach, does not prevent scoliosis. I think what we will find is that the short-acting treatments with antibodies of any kind need to be combined with long-acting treatments, such as bisphosphonates, to maintain any treatment effects that are made with these short-acting treatments. And so this is the acknowledgement slide to show that many people have worked on the results that I have shown you. The treatment program in Montreal was started by Francis Laurier and François Fassier almost 30 years ago, and many other people have contributed. So thank you very much.